everybody. This is the progress report for the first Wednesday in April. Because it's the first Wednesday of the month, I have the honor and the distinct privilege of being accompanied by my good friend, the Dean of the New Hampshire Senate, Lou D'Alessandro. Lou, thanks for coming back and joining us on the progress report.
Always a pleasure, Bob.
And it was a pleasure to see you honored at the St. Patrick's Day parade breakfast at the Tower, and everybody got to yell Lou. People like to yell Lou, actually, don't they? Lou, Lou, Lou. Right. And the roasters had kind of a hard time. It was hard to pick on you in an effective way.
Right.
I don't know. They did their best.
They did their best.
They did their best. And today, folks, we're happy to welcome back Phil Alexakos, who's what is your title, Phil? Deputy Director of the...
That's correct.
Deputy Director of the Manchester Public Health Department. And we are always pleased when Phil can join us because he's got a ton of great information about issues related to the pandemic and beyond. And one of the things I really enjoyed learning, knowing Phil, is just how important these people are to our public life in the city of Manchester. As Ludum reminded me one time, we only have two municipalities in the entire state that have a public health department, Manchester and Nashua. Yeah. All the other little towns and cities have public health officers, which my father was one because he grew up, he was a doctor in Goffstown where I grew up. But only in Manchester, Nashua, we have actually a public health department. And one of the things that I've learned, the doctors can do a fine job of trying to make you well after you become sick. But the mission of the public health people is to help you avoid getting sick in the first place. And that is an incredibly important mission, and we would all agree with that. And so these people do an amazing job. Phil's colleague, Anna Thomas, was very appropriately recognized a year ago as the Manchester Citizen of the Year, and well-deserved for what these people did to deal with the most deadly and widespread pandemic we've had since the infamous Spanish flu epidemic of 1918 through 1920. And we're going to want to talk about where we stand in regard to that and a bunch of whole other things. But that's our issue tonight, folks. And let me just remind you that we welcome calls. 603-640-3091 is our number. I think it's on your screen. It's not on what we see here, but I think it's on your screen. And to remind you that our show is now up on YouTube. Probably be up, maybe not tomorrow, but by Friday at least it'll be up. So if you missed us, you can see us there. And we also have repeats. Thank you, Phil, for coming back and joining us again.
It's my pleasure, and I guess it's apropos that this is National Public Health Week. If you didn't know that. So when we were scheduling that, I didn't put two and two together, but it's very apropos. And basically, I think we talked beforehand about what we'd like to discuss, and it's pretty much rapid fire, open mic night here with public health question and answer. So
yeah,
I brought some notes, and if I know the answer, I'll be sure to share. Yeah. If I don't, you'll have to have me back.
Okay. Well, I thought we would start, Phil, with the COVID pandemic and where we are now. You know, we've been through a terrible period of time. Starting in 2019 when it first hit, and then really, you know, the big hammer came down on all kinds of requirements. Everybody getting involved in testing and wearing masks and getting vaccines, or most people at least, and people was staying at home, trying to stay in their bubble, and without any kind of a grand announcement. It just sort of seems to be, in a way, coming to an end. And that's what I'd like you to talk about. We had these public health initiatives. They seem to me very important, but they've been controversial, which is kind of surprising, about should we really be able to require people to wear masks? Yeah. Can you really require people to have injections of vaccines into their bodies? Why not? We all do as kids against all kinds of childhood diseases. But it all became very controversial. I mean, it's shocking to me to see Dr. Anthony Fauci, having to, facing threats to him and his family for doing his very best to protect the citizens of the United States against this deadly pandemic. So let me turn to you and just say, as far as you people are concerned in our Manchester Public Health, where are we in regard to how we're dealing with this pandemic? Is it over? Should we still be concerned? Do we still need to get vaccines, boosters? Should we still all that stuff? I'm ready to let you listen.
So, I wish, like many people, that there was an announcement, or I think many of us were thinking, it'll be great when we're done with this. We'll have a party or parties, and we'll, celebrate what we've been able to accomplish. That's not the way that the disease progressed and evolved, and so there is no closure to this. And so what's very important right now is that we are in the process of collecting and analyzing feedback about the various elements of the public health and other responses. So we are collecting information from everybody that we worked with, whether we gave them technical assistance, whether we did a testing operation, whether we did a vaccination clinic, or any number of things, and we've solicited information. We're working with our own internal staff now to figure out what went well, what didn't go well, what needs to be improved, because when you talk about emergency planning or emergency management, whether it's public health or otherwise, you have to do something with the knowledge gained while it's still fresh to make adjustments for the next whatever it may be. And so we're in that phase right now, and we sort of have our own deadline of June 30th to come up with sort of the list of the good, the bad, and the ugly, not necessarily in that order, and take the plans that we had prior to the pandemic and make some very critical adjustments, and then get into a rhythm of testing various elements to see if the changes that we've made have been effective. So, there is no, this is over with. I think what we've learned, like any new disease, and I remember being here early on in the pandemic, and I said this, there's probably evidence of it, I hope, that...
I presume at that time we were all wearing masks.
Yes, most likely. And, I said, this is a novel disease, so we are going to be learning as we go. And that's not, doesn't inspire lots of confidence when you have to change messaging around what an illness that evolves or has a potential to evolve can do. So, I think the way that we messaged collectively, and, we get our guidance from the technical experts at either the state or federal level. There's a lot of discussion about how that all happened. And so we're going to be dissecting all of the elements of the response. Where we're at now is certainly we are tracking cases, but as the pandemic wore on, people had access to home testing kits, and those things aren't reported to anybody. So the data that we were collecting and getting at the very beginning was pretty robust and pretty, concrete. But then you kind of lose the value of what's happening in the community when you don't have all of the data points. So is COVID still here? Yes. Has the symptomology changed all that much? No. It's coming up on allergy season. And as you know, some of those symptoms overlap quite a bit. What we're learning is, obviously the vaccines are effective at giving protection. What they are not effective in doing is preventing illness altogether and or transmission. And so that was a huge, I think, misstep in terms of messaging, is that people wanted there to be a absolute, the vaccine is the gold standard, and then everything's going to be great. I think we all wish that.
Right.
As it turned out, it helped prevent serious illness, but it didn't prevent you from transmitting the disease. And we learned that over time. I will say it was amazing that we were able to, as a collective, produce a vaccine so quickly,
right.
A novel vaccine, because it takes us 6 months to get the annual influenza vaccine in a place where it's effective. And that's something that we have all the tools in place for. So I will say that the ability to ramp that up pretty quickly was a strong suit. But we are still going to have to deal with the pandemic. Are the cases, relatively stable? Yes. We haven't seen a lot of burden on the healthcare delivery system like we did before. Mm-hmm. But I will say that another lesson learned is you may have 100 beds available in your health facility, but you may not have enough staff to take care of 100 beds. So we're looking at bed counts, but we learned that it's bed counts and staff and personal protective equipment. So we're still tracking clusters of disease. If we hear about a facility or a school or something like that that has multiple cases, we will, reinforce the guidance about, hygiene, disinfection. Masks are not required. We know that they are helpful, and they're not, again, going to stop everything. And that's another place where I think people were very hopeful that would solve all of the problems. Nothing is that simple. I think that's probably the number one take home. So we are thinking about what went well, what didn't go well, what can we do better for whatever the next situation might be. We dodged a bullet with monkeypox. Right. I will say that we were thinking, oh boy, we're going to have to get into another campaign, and we had a lot of the practice to set up clinics very quickly and do outreach and things of that nature. So that was helpful. But yeah, the pandemic isn't going anywhere. I think it's probably better to use the term endemic, meaning there's a low baseline level of activity, and our focus rightfully should be on those who are at highest risk of serious illness. And what I did find interesting is, because you had asked me before, is there going to be another booster?
Right.
So most of us who received boosters got a reformulated booster that had the Omicron variant, and that was in the fall of last year. In Europe right now, they are starting a planning process to roll out another booster in addition to that one that we all received. The FDA and CDC have not come out with any recommendations about a subsequent booster, a reformulated booster. And what was interesting is that I was looking at England just to find something quickly. Their recommendation groups are people over the age of, I think, 60, people with medical conditions, the groups that are most susceptible to severe illness, but they aren't recommending it for the general population. So I think that might be a function of, let's focus on those who need, their immune system needs a refresher. And there's a lot of, COVID circulating at any given time, plus the protection from the vaccine seems to have reached sort of an equilibrium. So I think focusing on those who are at highest risk of illness, serious illness, is probably what any recommendations will look like moving forward. So I covered a lot there. So
you certainly did.
Wow.
And you made a couple of interesting points. Since we originally got into the testing, we used to go to the pharmacy and they would, do the swabs, and you got that data. Now that if people are doing home testing, you're not getting the data.
Right.
So how do you assess where we're at when you have that huge data gap?
So that's a great question. So we have some other systems in place across the state that are surveillance systems. So that's not in the NSA type of surveillance. I don't want people to get upset about that. No personal identifying information, but we can track. It's called syndromic surveillance. So if people are going to the emergency department with rash or gastrointestinal symptoms, that information gets aggregated, and we can track patterns and kind of know what the baseline of any type of syndrome or cluster of symptoms might be. And that might be the tip-off to something happening in the community. Now, that's very tertiary. That's after people have been sick. There are some other systems with partnerships with pharmacies and retailers that give us information about over-the-counter medication. So Pepto-Bismol, NyQuil, or acetaminophen, different medicine, we can see an uptick in any of those. That might be another step before you get really sick that may give us information that we can act upon or message about.
Kind of an indirect source of information.
Sure, it's like we're trying to move upstream. Ideally, you would be able to know that somebody was exposed and make sure that they don't expose anybody else. But that's sort of an early-ish warning system. And then other things that we track are school absenteeism.
Yes.
Now, that's not required in New Hampshire to report that, but we have a great partnership with our with the Manchester School District and the school nurses, and they know that if they see anything out of the ordinary, that they can call our public health crew, whether it's the environmental team that might look at air quality or food service or things of that nature, or our public health nurses. If there's, a rash that, maybe maybe there could be a vaccine preventable disease, we have that resource available. And I will say a strength of the pandemic, because I'm trying to find some lining of silver, that our surrounding school administrative units worked very well and sort of like a regional approach with us. And so when they have public health questions, they would call us because they knew that they could get, quick answers. And we have great rapport with Bedford, Goffstown, New Boston, Auburn, Candia, and Hooksett. Great partners. I don't know if our signal blasts that far, but I do want to say that Manchester School District and our surrounding towns were so helpful in both using their space, their staff, and their volunteers to work with us to vaccinate thousands of people and folks in their communities, which really was one of the more rewarding parts of the response.
So, as we're here today on the first Wednesday of April 2023, are people still coming down with COVID? Are they still having to be in the hospital? Are they still having to go to the ICU?
Yep, there are every day. We track. I say we collectively, public health and healthcare are looking at that data. We do get case reports of COVID. There are folks that are hospitalized, but it's not at the level that is taxing the healthcare delivery system any more than it already is, because that's pretty taxed as and so that is the case. It hasn't gone away in that regard, but the impact on society as a whole is diminished, and the interruptions on different systems are decreased as well.
I was interested to see, I think just today I began to hear for the first time, healthcare facilities themselves are beginning to back away from masking requirements.
Yes.
And that was quite surprising to me. I mean, because people are going to those places because they need health care because they're not feeling well. And now we're beginning to see, even in these types of in settings, a mask is becoming maybe a recommendation, but not a mandatory requirement. Is that wise, do you think?
Well, I can't speak for the facilities themselves, but I can tell you that when you're in any kind of congregate setting, obviously your risk of any respiratory illness is increased, whether it's flu, whether it's COVID. So, if you have any underlying medical conditions, it's prudent to think about yourself. The other thing, even pre-COVID, is when you went into a doctor's office or a clinic, usually there would be a sign saying, if you have fever, cold, cough,
they ask you
we
those
want
questions.
you to put a mask on because you're going to limit, not eliminate, but limit the amount of spread that that individual could do. So I really would say it's really a decision about your own internal risk or your own personal risk.
But aren't you a risk to others?
Potentially if you're infectious or if you're symptomatic.
Yeah.
I think the messaging about if you're actively ill, you should have a face covering. I think what I'm hearing is that it's for other folks who aren't necessarily sick, and then you have folks that, the contact, the personal, relationship is important in that setting, and maybe it's a well care visit, and it's not something where somebody's sick. So I think that it's situational. I think it's more about like the absolute piece that I think there's some fatigue there. But I can tell you in some settings, I'm going to wear my N95 if I'm trapped in a flying tube, let's say, for a long period of time. Just saying, I would prefer to have, I don't know my neighbors in that regard. So, things that you can control, make good decisions. And if you have loved ones that you see, it's that one layer out. You also may want to, take extra precautions.
Well,
but I think it's important to kind
a
of
couple
weigh
of
your
weeks
risk.
ago, I had the privilege of making a plane trip. I usually
I didn't use that word.
But I usually like the train because they don't have any middle seat. There are a lot of reasons. But in any event, I did take a flight from Manchester down to Florida to have a few days down there. Practically, there was a time when they weren't selling the middle seats. They are now, and the planes are full. And I would say, maybe a dozen people on that plane were wearing masks. That kind of astounded me. I mean, it really did.
I think the fatigue is real.
Yeah.
And then you really have to weigh what you can control and not make it adversarial, because I think what the disappointing part of all of this is not having a mindset of collective impact. It's all about me.
Right.
When you talk about an infectious disease, it's really not. It's not that simple, and it's not permanent.
Yeah.
I think people very absolute, and this is you're doing this, then you're gonna make me do this, and I don't think anybody. That's not how this played out. People are very mindful of their rights and responsibilities and liberties, but
Yeah.
when it's something that doesn't necessarily respect your personal space,
Yeah.
that becomes a little bit different.
Now, going back to the issue of vaccines again, I think one of the triumphs we had with public health here was the rapid development of vaccines, which turned out to be extraordinarily effective. They didn't keep us all from ever getting a breakthrough case. I had one myself, but I credit the vaccine with it being both short-term and very mild. And I think there's a lot of data that would say that was the thing. As we go forward, I'm thinking about what we've been through, and we're not entirely out of it yet. But what's going to be the next one? You mentioned monkeypox, where we just escaped. We barely escaped that. The COVID, we didn't escape at all. We had, a million deaths in the country, I guess, premature deaths. And it's not a question of if, it's a question of when, isn't it? I mean, really.
Yeah.
And are we going to be prepared to fight that while we're still dealing with the residuals, and they're not insignificant, of this pandemic? The next one's coming along. And I am quite concerned about that. One of the things I've heard something about is maybe, most of us like to go in the fall and get a flu shot so we don't get the goddamn flu, which is no fun. Nobody likes to have the flu. And it does kill some people, too.
Absolutely.
And
Yep.
and maybe in the future we'll have vaccines which will be your annual flu vaccine and your annual also provide protection against the next COVID variant. Is that something we can look forward to?
That's certainly possible. It really depends on the development and how well that they can prepare the vaccines, whether they can combine them or not. They are working on, and they haven't received authorization for home use yet, of a test that will test for flu A and B and COVID in one test, which would give really good information about what it is that you have to then decide what type of treatment you could potentially get. And I know one of the first times I was on, there was a big emphasis on what is the treatment, and as we learned, there were treatments available, and then they became ineffective because the virus mutated.
Right.
And so treatment is great to prevent serious illness, but even those can be infallible when we're talking about something that can mutate and change. So whether there'll be a combo vaccine with these two organisms, I'm not sure. But whether or not this becomes an annual vaccine, I think it depends on all of the data that they've been able to collect. Because remember, this was happening in real time, and in order to now go back and study the efficacy and figure out what tweaks might need to be done, and to do some other studies, now that the urgency is sort of waned, it can go through that process.
And what about the residual from the vaccine, and how we're addressing that now? I'm told that there are still people in the hospital because of the vaccine, because we can't place them, and that's a problem with manpower shortages. But how much of that still exists? How many of those beds are still occupied? And what's the relationship to that, and the cost factors that are being occurred around our state as well as around the nation? But I've heard there are some people that have been in the hospital for 100 days.
Yeah, once you're intubated and put on a vent, that's a lengthy proposition in terms of stabilizing somebody and then when they're ready to come off. What the cost value is, I think that would be compelling to some that maybe weren't compelled initially with some of the arguments around some of the interventions, whether they be vaccination or masks and things of that nature. Putting a price tag on the cost to the healthcare delivery system, especially when it's uncompensated care, or if it's paid out of Medicare and Medicaid, where the reimbursement rates are not even close to the private market. That would be a very compelling study to do for sure, to make arguments. And the way I look at any public health issue is obviously there's a cost benefit component, but there's a return on investment component.
Right.
So one of the issues that's non-COVID that we're now revisiting is childhood lead poisoning prevention. And so looking at the data, if you invest X amount of dollars, you can prevent however many dollars in societal cost, whether it's education or healthcare or judicial or you name it. Making those arguments is very compelling, but getting the solid data to make that argument, because you have to track those people that are impacted for decades. And so I think the dollars and cents argument with the hospitals is easier to track because they're very acutely aware of it. But I think that's a really good question that hopefully we'll get some answers to show that prevention benefit.
Well, I think that what we're seeing across this state is tremendous pressure on the hospitals.
Yeah,
tremendous pressure on the hospitals, and as a result of that, and that component, the traveling nurse component, which has really exacerbated this situation, you've really got to do some very effective management, and data collection is so important, and then the fear of letting somebody out when there's no place to put that person becomes a significant problem. And I know we're dealing with Medicaid rates, all right, Medicare, Medicaid rates, and Governor has an increase in his operating budget that he submitted. The House is handling that as we speak. But so those rates in some instances are just so low that you lose dramatically. That tremendous loss of money. That has to be dealt with, and pressure on the hospitals to maintain beds. Again, another very, very serious situation. And as Bob pointed out, we only have 2 cities in the state of New Hampshire that have health departments. Only 2. And who's responsible in the local communities for health? They have a health officer to some extent. What's the criteria to be a health officer? And these are things that I think this pandemic has forced us to look at and to evaluate. And then we've got to make some changes as we go forward, because we're going to have this again. There's going to be another pandemic. I mean, it's just going to happen.
It certainly is.
And the question is, how well prepared will we be when and if this comes? And with regard to the mask situation, I spent a little time in China, and they're wearing masks all the time. And I can understand why. The air is terrible.
Yeah, I was going to say that's probably the primary
They have
reason.
another reason to wear masks in China.
sure
The
do.
air pollution is awful.
But boy, they
But it's not stigmatizing like it is here.
No, exactly.
It's part of the cultural norm.
Right.
Yeah.
And here for a while, most everybody was doing it, and then as kind of things started kind of going on, you were then again the outlier if you were wearing the mask, and people are self-conscious. We're humans, and so you have to stick to what's important for your own well-being and the well-being of your loved ones, and if you don't like it, don't comment about it. Just go on your own business, and I think everything's become so us and them, and all of this. It's sad, and I hope that we can, get past that.
Yeah. That's another thing I wanted to talk to you about, Phil. I'm sorry, Lou. I didn't really realize this, but I guess, leading up into this pandemic, the United States public health system was considered kind of the gold standard. You know, the CDC was considered one of the great public health organizations in all the world. And, you know, it's brutal what's happened to all of us, including our public health services in this epidemic. If we come out with a health system, which you're part of, is it more in jeopardy than it was? I'm thinking about things like the push against the authority of our governors, including our governor here in New Hampshire, to declare a public health emergency, and the pushback against the requirement for people to use masks and to, you know, social distancing, actual distancing. So, I guess they call it social. I mean, you know, if we come out of this where you feel like we have the strength to deal with the next one, or are we facing a weakened public health system? I'm not just talking about you and Anna here. I'm talking about, you know, at the national level.
Yeah, I mean, I think our collective evaluation of where we're at will be borne out by what we call our after action review or after action report, which is that sort of summary of all of the goings on. And the way we break it out is into capabilities. So the public health system is responsible for 15 different kind of segments of work, anything from mass medical countermeasures, which are vaccines and antibiotics, or non-pharmaceutical interventions, which are isolation and quarantine, social distancing, or communications and things of that nature. So we're going to evaluate each element because that is what the system across the country.
Is this the report you're talking about that's coming out pretty soon?
Hopefully by June in a final version. And so every entity that was involved in the response should, if they're not compelled to, do one of these reviews, because these 15 elements that some of which I mentioned, those are things that every health department or public health system across the country are supposed to be working toward being proficient in. So it's sort of a standard set of deliverables. How that happens in each state is somewhat different. In New Hampshire, public health emergencies are operationalized at a regional level. That's why we have strong partnerships with our surrounding towns in that regard. But around the state, there are 13 regions. They are not all at the same level. The state public health department, public health services is looking to do a review of where we're at, and hopefully sort of what we submit for our after action will kind of inform that process. But you know, what's going to happen for the next pandemic? I was looking at an infographic that talked about different sectors of the public workforce: teachers, police, EMS and fire, and public health. There were data points on each of them, and then they got to public health, where it was like 40,000 public health workers during the pandemic either retired or left. So basically, yeah, I have concerns about what has happened to the existing complement and how we structure something that will be effective and efficient moving forward. And you know, that's sort of our mission, is to look at what we do as a city health department, but also what really happened during the pandemic and what was said to have happened and what actually happened. You know, we'll give our perspective, and hopefully everybody at the policymaking level will be able to make informed decisions about, like, what do we need to invest in? Surveillance system. There's a whole bunch of components of the response that made it more difficult to do it efficiently that we can fix and address. But I probably have the most, I don't want to call it heartburn, but the most concern about developing the next wave of our public health infrastructure in terms of workforce.
Yes.
Because, you know, we have some clinicians, and costs, to your point, Senator, you know, you could make a lifetime's worth of income if you were a traveling nurse over the last 3 years.
Yes.
And good for them for being valued, but I don't know that same value is placed on other sectors of the workforce that you know, are integral to the response. Mm-hmm. But we'll
We'll see.
We'll see. We'll
Right.
we'll put it out there and hopefully have some good discussions about it.
So when these bills are coming up in the current legislature, and you'll know more about this than I do, maybe you can add to this, but there's been an effort to really cut back on the authority of the governor to declare an emergency. And did your office get involved in that at all? Did you go up and testify? And what'd you say?
So the way the process works for us is we get a list of bills.
Right.
They put out a list of LSRs with keywords, but as everybody probably watching knows, you have to be really on top of what's happening because things are added, subtracted.
Right.
Sometimes they don't resemble anything having to do with the bill.
Yeah.
Right.
Not great, but there were a whole host of bills having to do with vaccinations.
Right.
One of the ones one of many that really gave us concerns because a lot of these things have an intent, whatever group is sponsoring them, but there are a whole lot of ancillary, I call them unintended consequences.
Right.
I'll use one bill in particular that we were really tracking, was a bill that said that there could be no vaccinations given on a school campus 2 hours before, during the school day, or 2 hours after. And that was based on a couple of incidents out of thousands of vaccinations during some flu clinics, I believe. And if that had passed, I believe it was tabled, if that had passed, if there was a public health emergency, where do you think we're doing all of our clinics? Schools.
Right.
So we would be prohibited from doing that. I mean, that kind of stuff, people put stuff forward, and hopefully, those who, have a response capacity, we don't have a lobbyist who lobbies on our behalf. We don't have a designated
Maybe you should.
bill tracker. So we have to try to stay on top of it.
Right.
Generally speaking, if it gets to the point where we have we want to take a position, we have to go to the mayor or a mayor board of aldermen to say what our position is and articulate that and be approved to go talk. I could go up as Phil Alexakos citizen, but those in the realm of public health know that I'm also Phil Alexakos deputy director, so
Right.
it's impossible for me to take that hat off. But we have gone up on occasion. Generally, we will go to the Senate if we have a bill that starts in the House
Right.
to see what happens to it first. But sometimes we will put forth. There is a lot of, to your point, Bob, a lot of effort to stymie regulations at
Yes.
the local level. There's a bill being considered about any sort of local public health ordinances have to go to basically a town meeting in order to get put in place. So basically, I look at that as we don't want towns passing mask requirements. So we're going to make it very difficult for any kind of public health, anything to get passed, which again has other unintended consequences.
Sure.
So there's a lot of stuff to keep. Every time I say, "Wow, we really have to watch what's going on," I think this session might take the cake.
Yes.
And
It does.
and we will figure out what has an impact to the citizens of Manchester and our ability to serve them and look out for their well-being as a community and and try to have a dialogue with the representatives locally and elsewhere to just make sure that they know all of the repercussions of some of those
Oh, sure.
possibly well-intended efforts.
Right.
I guess we've got a call.
All right.
Hi, caller. Welcome to the Progress Report. We're happy to have you join us. Have you got a question or comment for us or for Phil? Hello?
I lost him.
Please call back.
Right.
Please call back.
We'll be here.
Yeah, right.
We got a few more minutes. If you want to call back, we'd be happy to have you participate in our show.
I want to make a follow-up point to what you just said. I believe that
Hi there, you there?
It must be.
Hello?
Hi.
Yeah, that's it.
There were over 1,000 pieces of legislation offered by the House. Over 1,000 pieces of legislation. Wow. On the Senate side, I think close to 700. So look at 1,700 pieces of legislation. And talk about tracking legislation and what that legislation looks like from the day it's put on the floor by Legislative Services, and what it looks like when it gets finished, a committee, an amendment that takes place, little tweak, little change. And I think we've seen a lot of that this year. But I think the most significant thing that we can attribute to this legislative session is the personal nature of legislation, personally directed, because you have segments of this population that have very personal reasons for being there. And that kind of legislation causes me great concern, really great concern. And the fact that in the public venue, we only have 2 public health departments in the state. These bills affect everybody.
Yeah.
You know, and who's going to testify? We've got that caller, Bob?
Yeah, let's see if we do. I don't know.
Well, the person's trying.
We'll try again, caller. We'll
Right.
try and get you on. We're sorry.
Maybe
we
the
have-
booth can take a message and pass it to
on
us.
to us.
Yeah.
But you take a look at that stuff, and we're getting down to the point we've had crossover, and tomorrow they'll vote on the budget. So we'll get Senate. We'll get the budget. Senate bills are over in the House, and I'll tell you, I've got 4 or 5 bills that they're tweaking them in the House, and it concerns me. Obviously, when you produce a bill, you think it's rather straightforward and contains the information that they need.
Third
But,
time will be a charm.
Third
All
time's
right.
a charm. Okay.
Hey, caller, you with us?
I am. I'm sorry.
worries.
I don't know. The gremlins are at work.
I guess so.
I'm listening to your guest. I'm very interested in some of the points that he made. But I have this concern. You know, he's not elected. This guest is not elected. He's a public health official, but he's not elected. And so much information is coming out now about what happened these last 2 years. Senator D'Alessandro, you are elected. You're elected by the people of Ward 10, and if we don't like the job that you're doing, you know, we have recourse. We can call you. We vote for you. You know, so how does this balance out that public health officials who are not elected, and thank you for saying what you did about, you know, you wear a certain hat here, and so even if you do show up as Joe Citizen, which I would never say, you know, you don't have a First Amendment right to speak your piece, but you know, are these taxpayer dollars being spent to promote a certain public health position? And we don't have a way to vote you out of office because you're appointed. And I'm going to hang up and listen, but these are the things that go through my head as I watch the program. But I thank you for the opportunity.
Oh, thank you.
Thank you
So
for calling.
I think accountable government is critical. And I've worked with people from all different layers of government. And the further you get away from the home base, the less accountable people are. It's just geography, it's distance, all of that. If the city of Manchester has a unique need and the data suggests that, or a partner agency or citizens want to comment, provide input, the mechanism for doing that is to go to the Board of Mayor and Aldermen. As a public health official, I cannot declare something to be in effect. For instance, when there was a mask resolution that was passed by the Board of Mayor and Aldermen, it wasn't actually even a mandate. It was like a strong suggestion. That has to go through the Board of Mayor and Aldermen. So if I have a public health opinion based on the evidence that I have before me or my colleagues have before us, we would put that forth to the Board of Mayor and Aldermen, and ultimately they will vote on recommendations from us, police, fire, public works. So I can't unilaterally declare something.
You certainly can't declare a state of emergency.
I can't even declare things at my own house. So for me to take on more than that would be hypocritical. But yeah, there is accountability. So I hope that the caller, hears that. There's no unilateral just decision making. Even in an emergency, the public health officials at the local level don't have that ability. That there's a process, and public input is critical in that.
Very, very well said, Phil. And a good question. Thank
thank
you,
you
man,
for that.
for calling in.
I think that's a common
It's a good
thought.
question,
Yeah,
you know.
it is, yeah.
We end up in this country with not direct democracy, but representational democracy.
Right.
And, I think that's the way it should be. Sometimes I think we go overboard with referendums and recalls and things like that, which I think is very fortunate we don't have in New Hampshire. Phil, I don't want to say anything more about the COVID situation and the public response to it. I'm kind of ready to move on if you are.
Sure. Yeah.
And another subject that was here before COVID became a pandemic and will be here with us after it's over, which isn't quite yet, the opioid epidemic. And that's got to be a matter of major concern for you public health people. How do you think we're doing with that crisis? And what do you think needs to be done that we may not be doing?
So thank you for bringing that up. It definitely is something that we've been grappling with well before the pandemic. One of the things that we've been able to do recently is the health department wrote a grant for a few $100,000 to NACCHO, which is the National Association of County and City and County Health Officials, and CDC, to get funding for technical assistance and resources to address overdose spikes in the community. So some folks may have noticed that a few months ago we put out a spike alert, essentially, meaning that in pretty real time, within 24 hours, our data collection sources, which I'll talk about in a second, indicated that we were seeing something abnormal with fatal overdoses. So these are opportunities to flood areas or sectors with resources and outreach and other tools that have been proven to be effective in preventing fatal overdoses in other communities. So the other communities are New York City and other large communities as part of a collective across the country, and we were lucky to be selected as part of this group. So we get real-time technical support. We are beginning the interview process for targeted focused outreach workers, and these are folks with experience in substance use disorder, mental and behavioral health, that cover a lot of different layers to this very complicated issue. And so these are resources that we've been able to bring in that aren't local tax dollars, and this is a way to deal with something that's very tertiary, which is fatal overdose prevention. In public health, we try to work upstream of the issue, but right now it's critical that we prevent people from dying and use all the tools that we can and glean that information from places that have been battling this longer.
Yeah.
And I will say we have really amazing partnerships with our first responders, our fire department, our police department. Lieutenant Matt Barter is a rock star. He is a data guru, and he has developed the algorithm which gives us sort of a real-time, almost real-time indication that something is trending in the wrong direction so that we can get those resources out. And also AMR, which is our emergency medical services. So we are all working collectively, because one of the important things is looking at all of our different pieces of data. Some of them are quicker than others, but we also want to avoid any overlap or double counting, and we want to have the best available information, not only in the short term, like the immediate, but also trend. And so these are all important things that we're lucky to have strong partnerships that we can get people together to tackle that.
I just saw a story that today, or very soon, Narcan, this drug that can save people's lives who are in an overdose crisis situation, is going to be all over the counter at drugstores. Would you recommend citizens to get that? And is there a danger of misusing it, or do you need training, or what's your feeling about that? If you can save somebody's life who's in a crisis, you certainly want to be able to do it.
So that's great, because the interesting thing about opioids is Narcan is very specific to the receptors where the opioids bind. And so by giving someone Narcan, you're not going to cause another problem. It's fairly benign in terms of you're going to save someone's life from overdosing on an opioid. That's a long time coming. You can get Narcan through the doorway. That is something that is available. But we are also looking to set up some training opportunities so that people can feel comfortable doing it. I think
that would be very good.
There are different delivery systems that are straightforward. Some are more complicated. So hopefully the tool that is available more publicly is just plug and play. You basically take it out of the package and deliver it nasally. The first ones that we got, you had to crush an ampule, and it was almost like a barrier to try to do it. You felt like you weren't comfortable doing it, but there's no harm in giving that. What is important, though, is if someone does administer Narcan, that you still call 911, because depending on how long the Narcan stays bound to those receptors to prevent the opioid from going there, you could later on, if you have a lot of opioid in your system, overdose after the Narcan wears off. The other complicating thing, which I'm sure people have heard about, is xylazine, which is an animal tranquilizer that is getting blended with the fentanyl and opioids, which have a whole different constellation of health impacts. So just because you give Narcan, it won't be effective necessarily if there's other things. And right now, we don't have real-time tools to know what we're dealing with in the field, and hopefully the technology will be there that a first responder could know very quickly that there's xylazine in, and then messaging can go out to let folks know. And ultimately we're looking at keeping people alive so that they have the opportunity to get better and to get well. But if you're not alive, we can't do that. And there are folks across so many different agencies that are out making contact with people, building trust, and the research is very, very clear that if you're going to make a difference, it's that constant presence and the visits that eventually, when someone's ready, you're going to be there when they're ready. And you can't force someone into recovery, and it's not easy. And it takes that personal contact with the hopes of getting people into treatment.
So we've only got a few minutes left, Phil. This has been a really good hour. Lots of great information. And it's spring, so the ticks are coming out.
Yes.
Oh, yes.
And I think we're not seeing the insects that we used to see. I have a whole concern about that whole thing.
Well, I think I know where you're going there.
The ticks are not diminishing. We have plenty of ticks, and they are very concerning for health. And let's talk about your advice to people about how to keep yourself safe when you go out and enjoy the spring outdoors.
Absolutely. I mean, New Hampshire is a great state. You can beach, mountains, lakes, all within an hour. I mean, it's amazing. And we want people to be outside and being active for all the good health promoting reasons. One of the things I like to talk about, things that used to not be typical when I was younger. We didn't wear sunblock.
Right.
We didn't wear bug spray. I remember being up in the back window of the Buick, waving to people, no seatbelt, things now are like, it's horrible to think that, like, oh my gosh, that used to be a norm. Well, we need folks to check for ticks daily as a norm. We need people to use repellent, and that's generally they're effective with ticks and mosquitoes. And there's always a lot of interest in West Nile and Tripoli, and yes, they can be severe, but your risk of contracting a mosquito-borne illness is minute. Your risk of contracting Lyme disease is about 1,000 new cases per year over the last 2 decades. And I'm sure we could do 6 degrees of someone that you know
Right.
who has or has been diagnosed or is afflicted with chronic Lyme
Yes,
or
yes.
ongoing symptoms.
that's a terrible
It is
situation.
it is debilitating to various degrees, and these are preventable things. And there are very effective repellents. Some are natural, some are DEET. That they are very effective. The CDC has a great tool, and I think EPA also has a tool on their website. If you put in repellent, it will tell you if it's effective against ticks and/or mosquitoes, and for how long, because you do have to reapply these things. But common sense, I know long pants is not what people want to think about in the scorching summer, but when you're hiking, tuck in your socks to your boots. Ticks, they quest, so they crawl up on the tallest blade of grass, and they just kind of wait for something, mouse, deer, human, to just go by. They're
We have that expression, tick you off for a reason, don't we?
yeah, for sure. And the sooner you can get the tick off, if you can get it off within 24 hours, that is optimal. But the longer it's on, the longer it has a chance to transmit Lyme disease if it's a deer tick.
And the ticks are the biggest problem. They're not the big ones.
No, it's the nymphs that you have a hard time seeing.
That's really, and they're hard to see.
They are.
Yeah.
And so you have to be really vigilant. So you have to find a partner who will be able to find the parts that may not be easy for you.
Yeah.
But kids, especially, it should be, you came in from playing. Hopefully they're outside playing and not doing video games all day. They come in, you do, the armpits,
Check.
the places to hide, the hairline, and do that check and make it part of the routine at bath time or shower time. And
Phil, we're out of time.
all right. Well, I'll have to come back and
You'll have to come
and
back.
we'll-
You always have so
we'll
much
talk about
information.
some other
Thank you for
interesting
being
stuff.
here. Thank you for
Thank
joining me today,
Thank you,
Lou.
and
And
you're very welcome.
I'll be
Thank
back
you.
next week with Mike Farley with a program that we will announce. You can watch this thing on YouTube, Instagram. Be up probably by Friday afternoon. So
Well,
if people missed it and they want to see it, they can.
And a wonderful
it's there
Easter
for
holiday.
everywhere.
A wonderful Easter holiday, everybody. Phil,
Yep.
Quallen, thank you so much.
My pleasure. Thank you.
Thank you.